The subject of my talk today is depression in adolescence. And we all know about sadness, and we've all experienced sadness, but have we experienced depression? So, in order to know more about that, one thing we can do is use people who experience depression and tell us about their experiences. And it was sort of fortunate that one of the people who have had depression was William Styron, who it wasn't fortunate for him, but it was fortunate for us in the sense that he was a very, very good author. And so when he experienced depression and wrote about it in his book, we got a glimpse of what it's like. So let's hear his words. Depression is a disorder of mood, so mysteriously painful and elusive in the way that it becomes known to the self, to the mediating intellect, as to verge close to being beyond description. It thus remains nearly incomprehensible to those who have not experienced it in its extreme mode. Although the gloom, the blues, which people go through occasionally and associate with the general hassle of everyday existence, are of such prevalence that they do give many individuals a hint of the illness in its catastrophic form. But at the time of which I write, descended far past those familiar, manageable doldrums. In Paris, I am able to see now I was at the critical stage in the development of the disease, situated at the ominous way station between its unfocused steerings earlier that summer and the near violent denouement of December, which sent me into the hospital. William Styron from Darkness Visible. So, from William Styron's description, well, I want you to talk about it in the forum for the class, because on the one hand, I think that he says that people do have an inkling about what depression is, and on the other hand, he's saying that they do not. So let's talk about it in the forum for the class. And what do people think? Do we know what depression is? Is it qualitatively different than sadness, or is it just quantitative? Now, a lot of people have very strong opinions about that. I would say that I just don't know. It could be that it is just quantitative. That's a lot of sadness is depression, and it could be something qualitatively different, just like, for example, jealousy is different than frustration. But let's leave that for the discussion online. So DSM-5 has this umbrella term called depressive disorders, and within it, it has two very important diagnoses. One is major depression, and the other is persistent depressive disorder. Please note that the often used term, also by professionals, of clinical depression is not in DSM-4. It just means that it's a depression that sort of crosses the threshold for being clinical. So that's clinical depression. But the two major diagnoses, the two major labels are major depression and persistent depressive disorder. This used to be called in the past dysthymia. In the past, before that, it used to be called depressive personality disorder. So this is something that is more of a personality nature, something that is more consistent, persistent, while major depression is more of an onslaught, just like William Styron depicts in his book. So apart from that, we have all sorts of relatives that are not as common, like premenstrual dysphoric disorder, like substance abuse depressive disorder due to medical reasons. By the way, this is very common because a lot of people who get old and start to have health problems, then the medical problems cause depression. So you'll see that a lot as well. But this is not exactly the most important in general, and not the most important for us since we're dealing in adolescence. So when a psychiatrist or a clinical psychologist diagnose major depression, they have to specify if it's severe, moderate, does it have psychotic symptoms, remission, meaning that it is it has retreated, sort of the symptoms have retreated, and so on. One more important one that I'll mention is with seasonal patterns, which means that you usually experience it more in the winter. It's also called seasonal affect disorder, which has the very nice acronym SAD, seasonal affect disorder. And of course, postpartum depression, so it's called here specifiers around birth. That's very, very common. So having the blues after labor, that's very common. We're talking about 80% of women having the blues. But when it comes to depression, it's 1 in 100, so it's 1%. It's also very high. And then with psychotic features, it's 1 in 1,000. And of course, it's very, very sad when someone has just given birth and she loses touch with reality. So what are the symptoms that DSM outlines for depressive disorder? It includes a chronic depressive mood most of the day, more days than not, for at least 2 years. I'll already qualify and say that when we're talking about kids, 1 year is enough to know that. We don't need 2 years. And you have to have at least 2 of the following symptoms: lack of appetite or overeating, hypersomnia or insomnia, so you can't sleep or you sleep too much. By the way, most people with depression have difficulties falling asleep and they wake up exhausted. So that's very, very common. So, and that connects to the next one: fatigue and low energy, low self-esteem, inability or difficulty concentrating, and feelings of hopelessness. So if you have that, 2 out of 5, with sort of a sad mood for 2 years in a row, more days than not, that would be considered dysthymia or persistent depressive disorder. Now, major depression, we're talking about more symptoms. A lot of them overlap, but some are new. And it has to include low mood and lack of interest or pleasure. Now, this second one is also called anhedonia, which is sort of the opposite of hedonism. So in hedonism, you just think about how to enjoy yourself as much as possible. A hedonist doesn't care about responsibilities and so on. He just wants to have fun. Then anhedonia means that you don't find any pleasure in anything, and that's of course very, very telling. So if your friend tells you that he's sad most of the time and that he used to be interested in stuff like books or movies, but now that doesn't interest him anymore, so that's a very, very strong sign of depression. So what are the symptoms? You have to have 5 of them: a depressed mood most of the day, every day, lack of interest and pleasure, that's what we just talked about, that's the anhedonia, weight loss or gain or increased or reduced appetite almost every day, insomnia or hypersomnia, a slowing down of thought and a reduction of physical movement, fatigue, lack of energy almost every day, feelings of worthlessness or guilt, inability to concentrate or think clearly, and recurrent thoughts about death, suicide, or actually trying to commit suicide. So in order to diagnose major depression, there has to be distress and or impairment of functioning, whether it's social functioning, workplace functioning, or academic functioning. Something needs to be not working. And the symptoms are not caused by a medical condition like meds or drugs. And differently than DSM-4, it can be diagnosed after a loss of a close person. So when we talk about grief, grief is of course natural, but it's different than depression. Someone who is grieving will have, for example, a very fluctuating affect. So it won't be just sadness like depression. People, when you see them after losing someone close to them, they're sometimes happy when they're reminded of all the good things that that person done. Sometimes they're very sad, and sometimes they're angry, and they're able to function. Where people with difficulty functioning, so it can be seen as a psychosocial catalyst. So that you already have some tendency towards depression, and then something really bad happens, and someone close dies, or so on. and you fall into depression. So another criterion that is discussed in DSM is that the source of the symptoms is not schizophrenia. And also it's very important to ensure for the clinician that there are no manic symptoms. Mania is when you feel a burst of energy and you just don't need to sleep and you have a lot of new ideas and some sort of narcissism and so on. And it's very important to diagnose that because it may not be major depression. It may be a bipolar disorder where you see the depression side of it. And if you would misdiagnose it and prescribe medication, you may cause a manic episode because you're using the wrong kind of medication. So it's bipolar disorder is very genetic and biological, and we know exactly the kind of medication needed for that, which is lithium based and not the usual depression antidepressants that we use for unipolar depression. So I'm going to use a case study to talk about depression. I'm going to use Elizabeth Wurtzel, who is a Pulitzer Prize winner and a very, very esteemed journalist, and she wrote a very, very good book called Prozac Nation. And she says that she has had depression since a very young age. She grew up in Brooklyn, and her parents divorced when she was 2 years old, and she grew up with her mother, and there were a lot of quarrels and disputes. I'll show you some clips from the movie Prozac Nation. And the father, she will describe him in the clips. You'll see he is very inconsistent, just disappears from her life for years. So 4 years before college, he didn't see her. And the mother has her own problems, anger management issues, and very anxious, and wants to really fulfill herself through her daughter. This is her. This is the real person, Elizabeth Wurtzel. And she describes depression that started in elementary school, and then she went to Harvard, and she got a very good scholarship, and then she was awarded the Rolling Stone magazine prestigious prize. So everything was working out, but then the depression hit, and also drugs and alcohol were involved, and she withdrew from all her friends. She felt rejected, went for therapy, did not believe in a therapist, and only agreed to start antidepressants after she made some suicidal gesture and decided that it's time to take medication. So we're going to see a clip from the movie, and we're going to talk about whether the symptoms of depression exist in Lizzie. This is sort of like also what you will be doing at the final paper for this class. So let's watch the clip where Lizzie's mother comes to visit her, and she sees her in a depressed mood. So apparently YouTube is not allowing me to embed the Prozac Nation clip here, so please go to the link below to Prozac Nation, Lizzie depressed with her mother. So in the clip, you could see that she has a depressed mood most of the day, almost every day. So we can take the first one off. She has interest and pleasure in almost any activity throughout the day. She's in bed, so I don't know if she's insomniac or hypersomnic, but still she's in bed all the time. She probably has some fatigue and lack of energy. And we could also see things that happen that are not in DSM. So for example, we can see how frustrating it is for the mother. So the mother is a very practical kind of person. She does not understand Lizzie. She says, why can't you just be normal? Why would you say such things? Why would you tell the university that you have mental instability and you have to be alone in the room? And how come you're depressed? It's going so well. You're in Harvard. You did everything you ever wanted to do. You won the Rolling Stone magazine prize. So how come you're depressed? She finds it very difficult to understand, and she wants to solve it. She's a doer, she's not in being, she's in doing. So she does not want to commiserate with her daughter. She wants to solve it. So, for example, is it that you're pregnant? That's something I can solve. I can pay for an abortion. I can do something about that. I can clean up your apartment. I can make you a pear tart for your birthday. All sorts of things that are irrelevant for Lizzie. She doesn't want this stuff. She needs to be where she needs to be. She's depressed right now, and she rejects her mother. She doesn't want her around, not because it may also have to do with the personality characteristics of her mother, but beyond that, she rejects her because depression makes you want to be alone. You don't want anyone. And that's a very important thing to remember, because if you ever have to support someone with depression, it's very, very difficult. And we also call it the vicious cycle of depression. So people reject the people that try to help them, and then they feel even more depressed because they don't have anyone to support them. So that's another thing we could see in this clip. And of course, we know case study that she had recurrent thoughts about death because she has attempted suicide and made some sort of gesture. I'm going to talk about suicide separately on a different lecture, on a different clip. So if you have to do this for your final paper in the class, then you take this kind of case study and you examine it and you say, okay, she has 7 out of 8 symptoms. She would definitely follow the criteria for depression. So let's talk about major depression vis-a-vis persistent depression. So major depression can only needs to happen for 2 weeks. That's it. So 2 weeks with 5 symptoms or more, that's what we call major depression. That's what we see in Lizzie. So you don't have to have 2 years of that, as we said about the persistent depression. It's usually much more severe. So when you see someone in a major depression kind of state, you'll notice it. It's really like they're totally deflated. They have very little motivation to do anything, very negative thinking, very poor mood, and sometimes also psychotic symptoms can develop, like hallucinations and delusions, things we'll discuss in the schizophrenia part. So basically, the patterns can be very, very diverse. So you can have months of depression, persistent depression, and then a major depression episode for a couple of weeks, and then remission, and so on. And it doesn't follow any specific pattern. But of course, once you've had depression once, then the odds of getting it again are much, much higher. So they differ, major depression and persistent depression, in intensity and duration. So in persistent depression, it's usually less intense, but much, much longer. I told you that it used to be called a depressed personality disorder. So it's really part of the personality that you're sort of depressed. Another very important thing for adolescents is that it doesn't have to just be crying and low mood. It can also be a lot of irritation. And that's what we usually see actually with adolescents, that they become very, very irritable. Everything irritates them. And of course, loss of interest and social withdrawal. And another thing is the low self-esteem. So they just cannot see anything good about themselves. Another important differentiation that needs to be done is between primary depression and secondary depression. So depression can be primary, and then and then usually we're talking about some sort of combination of proclivity on the one hand and life events. Now, when we talk about life events, everyone experiences bad things happening to them. It's the question of how you take it. So people with depression, obviously, they already have the predisposition, and then when they encounter a very difficult life situation, a psychosocial situation, then they fall into depression. But we also have secondary depression. So if you have any other psychiatric disorder, it may cause you to feel depressed, and that's also very commonsensical. So if you have anorexia, if you have schizophrenia, all these things make you feel depressed. So when you go to a psychiatric ward, for example, you'll see a lot of people with depression, because a lot of the people that have different disorders will have, in addition, also depression, because it being in a psychiatric ward obviously makes you depressed. Children who suffer from depression may develop behavioral or anxiety disorders. Anxiety and depression, they go very, very well together. And of course, when it's primary, then you know it's most important to deal with the depression. And when it's secondary, then the idea is that you have to treat the primary problem. Let's say, for example, obsessive compulsive disorder, and the depression is secondary. It may be solved just by solving the first problem. Of course, it's never that simple. You'll probably treat both, but when you talk about let's say post-traumatic stress disorder, of course you have to deal with the trauma first. That's the primary issue. So for many years, it's been widely accepted that depression disorders do not occur during childhood. But now we know that's not true. And in fact, we can see depression as early as 6 months old. It's called anaclitic depression, which means that it stems from the relationship with the parent. So when you have, for example, an absent parent because of, for example, depression, so the parent is depressed, and then you get very sort of apathetic, non-responding babies, and you can diagnose them with depression as early as 6 months. Of course, that's very rare. And as you go up in age, you see a higher and higher proportion of depression. So we're talking about 0.5% or so in kindergarten, and then about 2% in elementary school, and it goes higher and higher, and we're talking 10 to 20% in the general population. So what are the signs of depression in adolescence? So one sign is that all of a sudden you see some unexplained educational decline. So the person, the student has no motivation, absent a lot. This can be a sign of depression. Another thing that you have to bear in mind is that it will not always look like sadness. A lot of the time it will look like aggression, irritability. So you can see aggressive behavior that you haven't seen before. Of course, going into delinquency and drug and alcohol abuse, which are problems on their own, but it can also mean that someone is depressed. It's not always that when you're externalizing, it's an externalizing disorder. A lot of the time it can be an internalizing disorder, especially with adolescence. Changes in sleep patterns, all of a sudden spending so much time sleeping, and spending less time with friends, and in general the sort of social isolation is another sign of depression. And of course, dropping out of school, dropping out of activities. All of a sudden you're not in drama club, you're not in music, you're not in the youth movement. There are the visible signs. It's not just a coincidence that you choose to be sort of gothic. So you go for dark clothing, Billie Eilish music, increased preoccupation with art that deals with death, and so on. Decreased social activity I've already mentioned, and changes in eating patterns, significant weight loss, significant weight gain, both can be signs of depression in adolescents. So let's talk about what causes depression. What does depression mean? And of course, depression has been known throughout history. It's nothing new. And one of the first to talk about it was the Greek physician Hippocrates, who spoke about the different biles, the different humors, and how a balance of humors causes different personality types. So you can see here, for example, in the drawings, you can see the different personality types, and you can see back here down and on the right, you can see the melancholic type, the type that has an imbalance, too much black bile, too much black humor, which is called melancholic. And you can see the yellow bile guy, which is sort of phlegmatic, and so on. The different types. So melancholy was known, of course, for many, many years. And there are several theories. So you have to keep an open mind. Some are more biological, some are more cognitive behavioral, and some are more psychodynamic. And we're going to cover some of them. So just when we talk about genetics, let's do a very, very quick introduction to genetics. So there are illnesses that are chromosomal, meaning that we know exactly how they are transmitted from, they are not, excuse me, not transmitted, how they are caused by our DNA. So for example, Down syndrome is a trisomy of the 21st chromosome, and we can see it under the microscope even, but it is actually not hereditary. Down syndrome, it is not caused by transmission from the parents. It is caused by some sort of mutation that happens during the pregnancy. And the most important factor in Down syndrome is, of course, the mother's age, as you may well know. On the other hand, we have illnesses, and not just illnesses, also personality traits that are hereditary, meaning that if the parent has that, then the child has a higher percentage of having that as well. So, for example, here I gave the example of being nice. Just being a nice person is hereditary to a certain degree, of course. You don't even have to live in the same house, so the genetics will cause the person to be somewhat nice as the parents. It's transmitted in the genes. And some illnesses are both chromosomal and hereditary. Like, for example, multiple sclerosis. So we know exactly where it is in the genome, and we also know it's transmitted from the parents. Now, when we talk about DSM-5 diagnosis, it's always hereditary and never chromosomal. Because if it's chromosomal, it's no longer called a psychiatric disorder. It's called an illness. That, for example, what happened to Rett syndrome. So Rett syndrome used to be in DSM-4, and now it's not. It's in the book of illnesses. And Down syndrome is not in DSM-5 because, and no, it wasn't in DSM-4 either, because we know the exact chromosomal path. So of course, depression is hereditary. So you can see the numbers. We're talking about a correlation rate in non-identical twins of 20 to 45%, and in identical twin more than 70%. So if your twin has depression, your chances of having depression is it's about 70%, while in the general population it's 10 to 20%. So it is hereditary, but we do not know the exact genetic path. But another thing that we know about depression from a biological standpoint is that it has to do with neurotransmitters. And we're talking about quite a lot of them that have to do with that. Serotonin is the most famous these days, but also norepinephrine, dopamine, and acetylcholine. They are all important in understanding the biological causes of depression. These days, it's mostly serotonin, and I'll talk about that when I'll talk about medication. Freud's notion of depression was that it's anger and aggression that are turned inward. So you cannot express your anger toward an external force, and so you direct it inwardly, and that's the reason for depression. And basically the analysis, the therapy needs to help you come to terms with your own aggression, be able to be angry at the object of your anger, for example, your mother, your father, and so on, And if you're not able to do that, then it may result in depression. And also, the psychoanalytic model was relied a lot on anxiety to explain depression. So anxiety, for example, for expressing your anger, your aggression, led to depression. In modern psychodynamic theories, we can see the importance of early experience. So a lot of it has to do with the quality of parent-child relations. There's repetition compulsion, meaning that what you see in your parents' relationships, you sort of duplicate in your adult life. And there's also the fact that when you experience rejection, loss, and trauma, then you sort of become you don't have the energy to become a viable adult, and depression hits. And you can see that. Let's see a clip from the movie from seeing Lizzie and her father, and that sort of shows that's the connection that they make in the book and in the movie between her childhood and the development of depression. Please go to the link below, Prozac Nation. Lizzie talks about her father. Now, a theory that has really developed in the 60s and the 70s and took a very respectable place was the cognitive behavioral theory. And one of the first experiments that was done by Dr. Martin Seligman, where he looked at dogs. Actually, this one looks a bit like a rabbit, but it is a dog. And the dogs were they were given electrical shocks in two conditions. Some of the dogs were given hints when the electrical shock is going to come, and like the dog you see in the picture, could run away from it. And the other group did not receive such cues, and they would just have to suffer it. So the dogs that received the cues, they learned to avoid it, and they kept avoiding it. But the dogs that did not, they tried to avoid it at the beginning, but after a while they understood that they cannot avoid it, and were just, they were just depressed. They were just they learned. He called it learned helplessness. They became helpless. So I'm going to get another shock, whatever. And moreover, when they tried to give the dogs that were already in a state of learned helplessness cues, they tried to teach them, okay, this is when you're going to get the electric shock, run. They didn't. So they were already in a sort of situation where they already experienced helplessness, and nothing could change that anymore. So what Martin Seligman deduced is that this is what happens in depression. So you get hit once and again, and you get to a situation of learned helplessness. You no longer feel that there's anything you can do to improve your situation. So that's sort of an animal model of depression. So the cognitive behavioral explanation became very, very trendy from the 70s. And basically what they were saying is that depression is not an emotional disorder. It's a cognitive disorder. It stems from the fact that you have biased, flawed cognitions. So the fact that you actually look at situations in your life as catastrophic, and you always see the glass half empty and so on, that's what causes depression, and not the actual event in your life. It's also very philosophical, based on Epictetus and the Stoics, that used to say that it's not about what happens to you, it's how you interpret the situation. So the treatment is taken from the different approaches that I spoke about. So biological treatment has a lot to do with antidepressants. Today, the most common antidepressants are the SSRIs, serotonin selective reuptake inhibitors. which work on serotonin, as I said. And of course, there's psychological therapy. It can be more psychoanalytic or cognitive behavioral. Cognitive behavioral is considered more state of the art these days, considered a bit more effective. But there are other treatments, also psychoanalytically based treatments that are considered what's called evidence-based. And today we know that the best treatments are a combination of both medication and psychotherapy. That's the most effective. In very extreme cases, there are also so for what we call treatment-resistant depression, there are ECT, so electric convulsive therapy. It is not what you saw in One Flight Over the Cuckoo Nest. It's and there's also on my website an item about ECTs and how they're done in the Shalvata Hospital in Israel, and you can see that they're very humane, and for people who have no other choice, it's actually very, very effective. So I'm going to stop here with depression, and I'm going to do a separate one about suicide. Bye-bye.